Hello, everyone. I'm Dr. Carmen Puliafito, and I'm here today with Dr. Dilsher Dhoot of Santa Barbara, California. Dr. Dhoot, welcome back to Retina Synthesis.
Hey, Carmen, thank you for the invitation. It's always great to be on here with you.
Uh, you've gotten some experience with intravitreal gene therapy for neovascular AMD, and at the Hawaiian Retina meeting, you discussed the 4-year results of the OPTIC trial, which is an Adverum intravitreal agent. Can you tell us a little bit about the the drug, the gene therapy approach, and then discuss the trial?
Yeah, absolutely. So Ixavec is a combination of a evolutionized vector, which is an AAV7M8 vector that's been engineered for enhanced crossing of the internal limiting membrane and thereby increasing production then of its payload. And the payload in this case is aflibercept, which we're all very familiar with. The drug is injected into the eye via the intravitreal route, so no different than the types of injections that we're used to. And it's designed to effectively make the eye a biofactory for aflibercept to produce aflibercept and treat disease states like neovascular AMD. And we know, as you know, we have an unmet need with neovascular AMD, high treatment burden, and patients are receiving multiple injections. But we see long-term data is not very good to our patients. We see that there's robust improvements in visual acuity out to 2 years, but past that, 3 and 4 years, visual acuity drops off in trials like CAT or 7-Up. And so the goal with gene therapy is to provide a one-time treatment that can reduce burden, and in some patients actually reduce it all the way down to zero, if they're lucky. Of course, this being a very heterogeneous disease, it's hard to predict who that patient is. And OPTIC was the first in human trial. And so in this trial for Ixavec, there were two doses, the high dose 6E11 and the lower dose was 2E11. And the primary objective was evaluating safety and efficacy of Ixavec, with secondary objectives, of course, vision and anatomy and need for supplemental therapy. Patients were screened for a response to aflibercept, and if they had an effective response or received Ixavec at one of the two doses. And in OPTIC, there were actually two corticosteroid prophylaxis, either oral for 13 days or difluprednate for 6 weeks. And so in total, you had 4 cohorts, 2 doses, 2 oral versus topical corticosteroid prophylaxis. And patients were followed for 2 years in the original OPTIC, and then there was a 3-year extension trial. And so I presented the 4-year results, which is the second year of the extension trial at the Hawaiian Retina meeting. And so this population of patients was a existing, experienced population that had high injection burden, approximately 10 injections per year annualized, with mean number of anti-VEGF injections of 34 to 38 injections. So had been diagnosed about 3 to 4 years on average. And so there are minor imbalances in their baseline demographics and characteristics, but generally a high burden population. One of the interesting pieces that came out of the 4-year data was the therapeutic levels after one injection of intravitreal aflibercept. And what's interesting is that patients received their first injection of Ixavec, and then you can measure aflibercept in the aqueous, and it turns out that the levels are sustained out to 4 years, and in some cases we even had 5-year data showing sustenance of expression of aqueous aflibercept, which is neat to see, though there was variability within the patients. When it came to safety, which of course was paramount and the primary endpoint here, there was no Ixavec-related ocular SAEs, hypotony, vasculitis, retinitis, choroiditis. IOP was stable through 4 years, and inflammation was dose-dependent and responsive to corticosteroids. It did not affect the vision, and 100% of inflammation resolved by year 1. In my talk, I focused on the 2E11 dose, which is the dose that moved forward into Luna. And in the 2E11 visual acuity data, we saw sustenance of visual acuity. In fact, very nice to see when you compare that vision is maintained out to 4 years and not dropping off at the 3rd and 4th year like we see in the long-term trials that we have that I mentioned, such as CAT. Central subfield thickness was also maintained. And we saw a reduction in treatment burden, over 80% reduction in annualized anti-VEGF therapy. And it turns out that just under 50% of patients remain injection-free. So these are the real winners at 4 years. So I think everyone's a winner with that amount of reduction in burden. So that really was in a nutshell, the data that I presented, the 4-year data for Optic.
Well, that's certainly impressive. How many eyes were enrolled in these studies in total?
So there's 30 eyes enrolled in Optic, 60 in Luna.
Yeah, amazing. So inflammation has been a concern. And why is inflammation a concern?
Yeah, it's a really a sweet spot for gene therapy, right? The dose of gene therapy, that is now being measured with various doses, and we see that at higher doses we do see inflammation. The transfection of the cells can result in issues, including anterior and posterior inflammation, but also issues with IOP, especially if the ciliary body is affected, and so. It's really finding that sweet spot where you still have efficacy, but the dose is low enough that you don't see the inflammatory effects that all of the companies that are currently evaluating gene therapy are after. And it turns out that steroid prophylaxis is important in this regard too. To get that optimal dose, I think that all the programs recognize that there must be some level of steroid prophylaxis.
Was there any difference between the oral and the topical steroid use?
Yeah, it's interesting learnings because this has been an evolution of learning when it comes to prophylaxis, and it turned out that the patients did better with the topical, and so lower rates of inflammation with topical, and really you see a transfer now from thinking, even from intravitreal, which they tested in Luna, that really topical does the best for these patients in terms of prophylaxis.
So all the inflammation was gone at 1 year.
Yes. So by 1 year, 100% of inflammation was resolved, and the inflammation that did occur was treatable with topical.
And 50% of the patients were injection free after 4 years.
Yeah, just under 47% exactly, but yeah, 50% of patients, and these are patients who had high burden, 10 injections per year prior.
So you're familiar with all the different gene therapy modes of delivery. Where do you think intravitreal stands?
I think intravitreal is highly desirable, given that it's something that's in the wheelhouse of most retina specialists, and it can be done in the office. There's an automatic barrier to go to the operating room, though I find those results to be quite good in the subretinal programs. I think suprachoroidal is similar to intravitreal. It's within our wheelhouse. Certainly, retina specialists are not as familiar with suprachoroidal as they are intravitreal, but I think both, in-office procedures are quite favorable, given just the access.
Yes, avoiding trips to the OR is key.
Absolutely.
So, what are the next steps for this? So, which dose are they moving forward into phase 3?
So the phase 3 is using 6E10, which was an even lower dose than 2E11 that was studied in the Luna trial. And so the next steps are the pivotal phase 3 trials. The first one was Artemis, and the enrollment's complete there. The top line data is anticipated the first quarter of 27. And then the second pivotal phase 3 trial is called Aquarius, and that is currently initiated, and we hope to see enrollment complete sometime this year. And so the control will be aflibercept dosed on label versus a single intravitreal injection of Ixo-vec 6E10.
Well, this has been a very exciting discussion, and 2027 is around the corner.
It's coming fast. The years go fast.
Going fast. Thanks a lot for joining us today.
Thank you.